A military surgeon wasn't always trying to save your blood. Sometimes, the very first thing he reached for was a bowl. Not to wash a wound, not to collect water, but to collect the blood he was about to remove from your body. To a modern observer, it sounds impossible. A soldier has survived musket fire, artillery, or a bayonet wound. His face is pale. His pulse is weak. He's barely conscious. Every instinct today tells us he desperately needs more blood. Yet for centuries, many military doctors believed the opposite. They believed that too much blood, or blood moving in the wrong way through the body, could be just as dangerous as the wound itself. And so, while frightened soldiers cried out for water or begged for help, physicians often opened a vein with remarkable confidence, not because they were cruel, because they believed they were practicing the best medicine available. The idea of bloodletting stretched back more than 2,000 years. Ancient Greek physician Hippocrates proposed that health depended on a balance of 4 bodily humors: blood, phlegm, yellow bile, and black bile. Later, the influential Roman physician Galen expanded these theories, and for well over a millennium, they became the foundation of European medicine. Universities taught them. Medical texts repeated them. Military surgeons carried those ideas into every major conflict. Historical scholarship from institutions including the Wellcome Collection and studies of Galenic medicine confirm just how deeply these concepts shaped medical practice for centuries. To physicians trained under this system, fever meant excess. Inflammation meant excess. A racing pulse meant excess. Remove blood, and perhaps the body could restore its natural balance. On a peaceful day, that belief was dangerous enough. On a battlefield, it became something far more tragic. Imagine standing inside a crowded field hospital after a major battle. The canvas tent barely keeps out the rain. Mud mixes with pools of blood beneath hundreds of boots. The smell is unforgettable. A mixture of sweat, wet wool, smoke, human waste, and fresh wounds already beginning to sour in the summer heat. Stretchers arrive without pause. One man has a shattered thigh from cannon fire. Another clutches a chest wound that bubbles with every breath. A third has escaped with no obvious injury, but cannot stand without collapsing. Today, we recognize many of these men as victims of hemorrhagic shock. Their bodies are desperately trying to preserve oxygen for the brain and heart after severe blood loss. Military doctors of the 18th and early 19th centuries saw something very different. A rapid pulse, flushed skin in some patients, confusion, restlessness. Signs they interpreted as dangerous excitement within the circulatory system. So the lancet came out. The instrument itself was deceptively simple. A sharp blade designed to open a vein quickly. The surgeon tied a band above the elbow, located a swollen vein, and made a swift incision. Dark blood flowed into a waiting basin. Sometimes only a few ounces were removed, sometimes much more. There was no laboratory test, no blood pressure monitor, no understanding of oxygen transport. Karl Landsteiner would not identify the ABO blood groups until 1900, making safe transfusion possible only decades later. Before then, doctors had no practical way to replace what they intentionally removed. The terrible irony was invisible to them. Many patients became quieter after bloodletting. To physicians, that appeared to prove the treatment was working. But silence can mean many things. Sometimes it means relief. Sometimes it means the body no longer has enough strength to fight. And that heartbreaking misunderstanding would shape military medicine for generations. But this wasn't the worst part. The soldiers who survived the bleeding often faced an even more terrifying enemy that no surgeon of the time truly understood. The worst danger did not always arrive with the bullet. Sometimes it arrived hours later, after the surgeon believed the operation had been a success. A wounded soldier who had survived the battlefield was carried into a crowded hospital tent. His uniform was cut away. Dirt, fragments of cloth, and splinters of bone were visible inside the wound. The bleeding had slowed. He was still alive. To everyone around him, that felt like victory. But inside his body, another battle had already begun. The human body responds to severe blood loss with astonishing precision. Blood vessels narrow to preserve circulation. The heart beats faster. Hormones trigger every available reserve to keep oxygen flowing to the brain and vital organs. Modern trauma medicine recognizes this as a desperate survival response. Military doctors centuries ago saw the same racing pulse, but they interpreted it through an entirely different medical framework. To many physicians, the rapid heartbeats suggested dangerous excitement of the circulation. The patient seemed feverish. His skin could feel warm despite the loss of blood. Some became restless or even delirious as the brain struggled with falling oxygen levels. Rather than recognizing these as warning signs of shock, many believed they were seeing inflammation that needed to be controlled. The answer, once again, was often more bloodletting. This belief became especially influential during the Napoleonic Wars. The celebrated French military surgeon Dominique Jean Larrey revolutionized battlefield evacuation by introducing the flying ambulances, rapidly transporting wounded soldiers for treatment. Larrey himself was far more conservative about bloodletting than many of his contemporaries, relying heavily on rapid surgery and practical observation. Yet countless military physicians across Europe still embraced aggressive bleeding because prevailing medical doctrine supported it. Historians continue to note that 19th century medicine was a mixture of remarkable surgical innovation and deeply flawed physiological theory. Inside the hospitals, conditions made every mistake even more dangerous. Rows of men lay shoulder to shoulder. Bandages were reused. Surgical aprons stiffened with dried blood from previous operations. The same knives and saws passed from one patient to the next, wiped clean only with a cloth. No one understood bacteria. Joseph Lister's antiseptic methods were still decades away, and the germ theory of disease would not gain widespread acceptance until the work of Louis Pasteur later in the 19th century. The enemy hiding inside every wound remained invisible. A soldier whose leg had been shattered by a musket ball often faced immediate amputation. Without anesthesia, until the mid-1800s, speed became the surgeon's greatest skill. Experienced operators could remove a limb in only a few minutes. Assistants restrained the patient as the bone saw rasped through living tissue. The sound echoed across the crowded tent, mixing with cries from other operating tables. Those who survived the operation were not necessarily safe. Their remaining blood volume was already dangerously low. Then came fever. The wound became swollen. Its edges darkened. A foul-smelling discharge seeped through linen bandages. Flies gathered wherever they could. Today we recognize these signs as severe infection, sometimes progressing to gangrene or sepsis. At the time, physicians had no understanding of microorganisms. Many believed the pus itself was part of healing. Some even described laudable pus as a favorable sign, a belief documented in numerous surgical texts before antiseptic medicine transformed wound care. To exhausted surgeons, every worsening symptom seemed to reinforce familiar ideas. A stronger pulse? Perhaps more blood should be removed. A rising fever? Perhaps the body still contained excess blood causing inflammation. The treatment often matched the theory, even when the theory was wrong. Not every physician agreed. Some military surgeons quietly noticed that patients who had already lost massive amounts of blood rarely improved after further bleeding. Their observations planted the first seeds of doubt, but challenging centuries of accepted medical teaching was extraordinarily difficult. One successful recovery could reinforce old beliefs far more powerfully than dozens of unexplained deaths. The real problem was becoming impossible to ignore. Some soldiers were not dying from their original wounds. They were dying after surviving them. And the growing number of these tragic cases forced a new generation of doctors to ask a question that medicine had avoided for centuries. What if the treatment itself was making the wounded weaker? The question spread quietly through military hospitals, not in public speeches, not in medical schools, but beside hospital cots, where surgeons watched men fade away despite receiving every accepted treatment of the day. Again and again, the pattern repeated itself. A soldier survived the chaos of battle. His wound was cleaned as well as the era allowed. A limb was amputated if necessary. His bleeding appeared under control. Then his skin turned pale. His lips lost their color. His pulse became fast, but strangely weak. His hands felt cold. Today, these are classic signs of worsening hemorrhagic shock. Modern physiology explains that when blood volume falls too low, the heart simply cannot deliver enough oxygen to the body's organs. The kidneys begin to fail. The brain becomes confused. Eventually, multiple organs shut down. Research in modern trauma medicine has shown that replacing lost blood quickly is one of the most important factors in improving survival. But centuries ago, none of this was understood. Doctors could feel a pulse. They could observe breathing. They could see fever. What they could not see was oxygen. Without knowing that red blood cells carried oxygen throughout the body, physicians had no reason to believe that every drop of blood removed might also be removing the patient's ability to survive. The body's final attempts to compensate often fooled even experienced surgeons. As circulation failed, the heart beat faster. The patient became anxious. He gasped for air. Some tossed violently in bed, unable to explain why they felt an overwhelming sense of panic. To physicians trained in Galenic medicine, this agitation could resemble dangerous overstimulation. To modern emergency physicians, it is recognized as the terrifying sensation of a body literally running out of oxygen. The difference between those interpretations meant the difference between preserving blood or draining even more away. The tragedy was compounded by infection. Within days, many wounds changed dramatically. The skin around the injury stretched tight and shiny. Redness spread outward. The smell inside the ward became heavier each morning. Thick yellow or green pus soaked through layers of linen. Black patches sometimes appeared around damaged tissue as gangrene advanced, leaving flesh cold, lifeless, and unmistakably dead. Military hospitals developed odors so overwhelming that visitors frequently described them in letters and diaries. Accounts from the Napoleonic Wars, the American Civil War, and the Crimean War repeatedly mention air thick with decay, smoke, sweat, and infected wounds. Those eyewitness descriptions survive in military medical records and historical archives, offering a sobering glimpse into conditions before antiseptic surgery. Doctors searched desperately for explanations. Some blamed foul air. Others blamed climate. Many believed the patient's constitution had simply been too weak from the beginning. Few suspected that invisible organisms were invading every untreated wound. Even fewer questioned whether excessive bloodletting had reduced the body's ability to resist those infections. Yet careful observers began noticing uncomfortable facts. Patients who retained more of their blood sometimes recovered better than expected. Others, who had been bled repeatedly, often became too weak to sit up, too exhausted to eat, and too fragile to survive even minor complications. These were observations, not controlled scientific experiments. Medicine in the early 19th century lacked the clinical trials we rely on today. But experience accumulated slowly, case by case, campaign after campaign. The evidence did not arrive all at once. It emerged through thousands of heartbreaking outcomes that refused to match accepted theory. One of the most influential critics was the French physician Pierre-Charles Alexandre Louis. During the 1820s and 1830s, he introduced what became known as the numerical method, carefully comparing groups of patients instead of relying solely on tradition or authority. His studies suggested that bloodletting offered far less benefit than generations of physicians had assumed, particularly when used aggressively in inflammatory diseases. While his work did not end the practice overnight, it marked a profound shift toward evidence-based observation. For perhaps the first time in centuries, numbers began challenging ancient beliefs. But abandoning bloodletting created another frightening problem. If removing blood was not saving dying soldiers, then what could possibly replace it? That question would force medicine to confront one of its greatest mysteries, and eventually lead to a discovery that transformed every battlefield that followed. Once doubt entered military medicine, it could not be contained. The old textbooks still praised bloodletting. Senior physicians still taught it. Many hospitals still practiced it. But more and more surgeons returned from war with memories they could not explain. They remembered soldiers who had been too weak to survive another bleeding. They remembered others who recovered despite receiving little or none of the treatment once considered essential. Experience was beginning to compete with tradition, and on the battlefield, experience was a ruthless teacher. By the middle of the 19th century, warfare itself had changed faster than medicine. Rifled muskets fired heavier bullets with greater accuracy. Artillery became more destructive. Explosive shells shattered bones instead of merely fracturing them. The result was an overwhelming number of catastrophic injuries arriving at military hospitals within hours. Military surgeons suddenly faced hundreds of patients suffering from massive blood loss. No theory could ignore that reality forever. The Crimean War exposed another devastating truth. Hospitals were often more dangerous than the battlefield itself. British nurse Florence Nightingale became famous not because she invented new surgical techniques, but because she recognized something many physicians had overlooked. Clean water, proper ventilation, fresh bedding, nutrition, and basic sanitation dramatically reduced death rates among hospitalized soldiers. Her statistical analysis showed that disease claimed far more lives than combat wounds during much of the conflict. Her work, preserved in British military records and later public health research, helped transform military medicine from tradition toward measurable evidence. For the first time, careful record-keeping began replacing assumptions. Doctors started asking difficult questions. Which treatments actually improved survival? Which merely appeared to help? The answers were often uncomfortable. Bloodletting did not disappear overnight. In some regions, it continued well into the late 19th century. Old habits rarely vanish quickly, especially when generations of respected physicians have built their careers upon them. But another revolution was quietly taking shape, inside laboratories rather than hospitals. In the 1850s and 1860s, the German scientist Rudolf Virchow transformed the understanding of disease by arguing that illness began in cells, not in imbalanced bodily humors. At nearly the same time, Louis Pasteur demonstrated that microscopic organisms were responsible for fermentation and many infectious diseases. Soon afterward, Joseph Lister applied these discoveries to surgery, introducing antiseptic techniques that dramatically reduced postoperative infections. These breakthroughs attacked the very foundations of ancient medicine. Disease was no longer explained by mysterious imbalances. It had physical causes, observable causes, testable causes. Meanwhile, surgeons also gained another remarkable advantage: anesthesia. The introduction of ether in 1846, followed by chloroform shortly afterward, transformed the operating table. Surgeons no longer depended entirely on speed. Patients no longer had to be held down by several assistants while conscious. More careful procedures became possible, even though infection remained a constant threat until antiseptic methods spread. Still, one enormous problem remained unsolved. A soldier could survive surgery. His wound could remain free of infection. Yet, if he had lost too much blood, there was still almost nothing doctors could do. Some physicians experimented with transfusion, but the results were wildly unpredictable. A few patients recovered dramatically. Others died within minutes. No one understood why. The blood itself seemed mysterious. Sometimes it gave life. Sometimes it brought sudden death. Without knowing about blood groups, doctors unknowingly mixed incompatible blood, triggering catastrophic immune reactions. The procedure seemed so dangerous that many physicians abandoned it altogether. The missing piece would not arrive until the beginning of the 20th century, a discovery so fundamental that it would forever change emergency medicine, battlefield surgery, and the survival of wounded soldiers around the world. Ironically, the secret had been flowing through every human vein all along. Doctors simply had no way to see it. And once they finally did, military medicine entered an entirely new era. The answer had been inside the human body all along, not hidden in the heart, not concealed within the bones, but flowing silently through every artery and every vein. In 1900, Austrian physician Karl Landsteiner made a discovery that changed medicine forever. By identifying the major human blood groups, A, B, AB, and O, he explained why some transfusions succeeded, while others ended in sudden catastrophe. Blood was not universally interchangeable. The body could recognize incompatible blood as a deadly threat, triggering immune reactions that destroyed red blood cells within minutes. For this work, Landsteiner was later awarded the Nobel Prize, and historians of medicine regard his discovery as one of the greatest turning points in modern healthcare. Suddenly, a possibility that had seemed almost impossible for centuries became practical. Instead of removing blood from weakened patients, doctors could begin replacing what had been lost. The transformation did not happen overnight. Early transfusions still faced enormous obstacles. Blood clotting limited how long it could be used. There was no refrigeration suitable for widespread storage. Hospitals had to rely on direct donor-to-patient transfusions, often performed under difficult conditions. Then, another series of breakthroughs arrived. Scientists developed anticoagulant solutions that kept blood from clotting too quickly. Refrigerated storage improved. Blood typing became routine. During the First World War, military physicians began establishing some of the earliest organized blood storage systems near the front. By the Second World War, blood banks had become an essential part of military medical planning, allowing wounded soldiers to receive life-saving transfusions within hours of injury, rather than hoping a compatible donor happened to be nearby. Modern trauma medicine grew from those hard-earned lessons. Today, doctors understand that severe blood loss is not simply a matter of low volume. Blood carries oxygen, nutrients, immune cells, and clotting factors that keep every organ alive. When a trauma patient arrives at a hospital after a serious injury, medical teams work rapidly to control bleeding and restore circulation using carefully matched blood products. Massive transfusion protocols, developed through decades of civilian and military research, have saved countless lives in conflicts from the late 20th century to the present day. Looking back, it is easy to ask how generations of intelligent physicians could have believed that draining blood would save a dying soldier. The answer is more complicated than it first appears. Those doctors were not ignorant. They were working with the best knowledge available to them. They observed carefully. They studied respected authorities. They genuinely wanted their patients to survive. But they lacked the scientific tools to understand what blood truly was. Without microscopes capable of revealing cells in detail, without knowledge of oxygen transport, without germ theory, without blood typing, and without controlled clinical trials, They interpreted what they saw through the only framework they possessed. History reminds us that sincere belief is not the same as scientific truth. Medicine advances not because people refuse to question tradition, but because they are willing to test it, even when the answers overturn centuries of accepted wisdom. The image of a military surgeon opening a vein in a wounded soldier feels almost unimaginable today. Yet that practice endured for generations because it seemed logical within the medical understanding of its time. What eventually replaced it was not a single miracle discovery, but thousands of observations, careful experiments, and the courage of physicians and scientists who accepted that long-held assumptions could be wrong. Every safe blood transfusion performed today carries the legacy of those painful lessons. Every trauma patient who survives, because blood can be rapidly replaced, is living proof of how far medicine has come. The battlefield has always revealed humanity at its most desperate, but it has also revealed something else: our extraordinary ability to learn from failure. The men who endured those primitive hospitals could never have imagined operating rooms with sterile instruments, blood banks stocked with compatible donations, antibiotics, advanced anesthesia, and trauma teams capable of replacing liters of blood within minutes. Their suffering helped shape that future. It is a sobering reminder that many of the medical treatments we now take for granted were built upon centuries of trial, error, sacrifice, and relentless scientific curiosity. If stories like this remind you how extraordinary modern medicine really is, consider subscribing so you won't miss the next forgotten chapter of history. And if one moment in this story surprised you the most, let us know in the comments. Because sometimes the most fascinating battles in history were not fought between armies. They were fought against the limits of human knowledge.